Good morning, Ashik. You can start your presentation. Ashik, we are not able to hear you.
Good morning, sir. Am I audible now, sir?
Yes.
Okay. Good morning, everyone. My topic for today will be RSA and TSA. It's a very vast topic, and I'll try my best to finish it within the allotted time period. Starting off without further delay, these are the order in which I would like to present my PPT. I'll first talk about the anatomy, history, biomechanics, and the indication, contraindications, results, and complications of ATSA. Then I'll be talking about RTSA, reverse shoulder-to-shoulder arthroplasty, and following the same order, history, biomechanics, advantage, indication, contraindication, complications. Starting off with the anatomy, shoulder joint is much like the golf ball sitting on a tee. Has a extreme mobility, but it has come at the cost of stability. So it has been kept in place in the shoulder joint through the dynamic and static stabilizers, dynamic being the rotator cuff and the ligaments and soft tissues, static being the structural components. Like I said, shoulder joint is one component which is given up on its stability for achieving its extreme mobility. Mobility that is achieved due to the variety of muscles and rotator cuff and soft tissues that has been attached to the joint, to the humerus well as to the glenoid, and achieving multiple force vectors. Unlike the hip, which prioritizes stability over mobility, shoulder is the exact opposite, that desires mobility more than the stability. So what are the conditions affecting the shoulder mobility is proximal humerus fractures. It can be tumors of various kinds. It can be rotator cuff arthropathies, as you can see in this X-ray, Hamada grade 6, leading to stabilization of the acromion and the fibrillization of the humerus. Can be massive rotator cuffs. So it was found early on that ORIF is just not the answer that will serve all these problems. So hence develop the shoulder arthroplasty. So shoulder arthroplasty comes in varieties of shapes and forms. It can be the hemi, it can be total shoulder, it can be reverse total shoulder. Each of them was developed for overcoming the shortfalls of the previous one. So in this, we're going to talk about the total shoulder and the reverse total shoulder. Total shoulder is the anatomic variant where the ball component sits in the humerus, and the reverse total shoulder is the exact opposite. It's a non-anatomic variant where the ball component, or the glenosphere in this case, sits on the glenoid. So it has advanced so much so that we can almost promise the patient that he will reach a pre-injury state of activity or even slightly better in some cases. Coming to the history, first shoulder process was done by French surgeon Pin for tubercular arthritis, which lasted for a whole of 1 year before it failed due to the recurrence of infection, not due to any other causes, but infection recurred, so the implant failed. But he was very sure to make it out, to point it out to the rest of the world that for the 1 year that it lasted, gave the patient a reasonable, acceptable level of mobility that enabled the patient to carry out his daily living activities. This was noticed by Dr. Charles Neer in 1951, who used a vitellium prosthesis to treat a proximal humerus fracture. And he followed it up with a paper in 1970 showing 90% excellent outcomes in 43 patients of proximal humerus fractures. However, when the American and the European groups tried to replicate him, they found unacceptable levels of glenoid loosening and very poor clinical outcomes. At the same time, when the rest of the world was struggling, he published another paper in 1982, 12 years later, with 250 arthroplasties, and he had performed this for a variety of indications. He not only did that, but also subclassified the indications and published a paper on showing the outcome of each of these indications, how they are for proximal humerus fractures, how they are for cuff problems, and all those things. So he further subdivided it, went into detail regarding that. So what were these problems that the rest of the world was struggling with? So the first generation was actually the monoblock. So monoblock is just one single structural piece that acts as the ball and the socket for the humerus, for the shoulder joint. So problems with these were anatomical variation. Everyone's size is not the same. The size of the shoulder joint can be smaller, can be larger, depending on the body structure of the patient. Also, the space available for the joint, how much the soft tissue components can be stretched or loosened. Diameter of the medullary canal. A young healthy adult will have a very thick cortex with a narrow medullary canal. However, with an elderly patient, they can have a very broad with cortical thinning, very broad medullary canal. So that was also a variant. Then glenoid component fixation. They did not have a variety of options like we have right now, like the cement or the porous coats or the screws to support the poly. So in those cases, fixation was slightly more difficult. So this gave rise to the second generation being the rise of the modularity. Need's motor block was subdivided into components at the head and the stem of various sizes to match the need for individual patient. That also created some problems. Problems like head positioning in the horizontal and the vertical planes were found to be suboptimal. And how much of this head size? What is the appropriate head size? How much should we tension the rotator cuff? Because if you had planted a head size that is larger than the original, they found that there was a problem called overstuffing, where you stretch out the rotator cuff, especially the supraspinatus, as you can see in this figure, and it causes the shoulder to undergo a secondary cuff failure because of the irritation or the stretching out of the rotator cuff muscles. Then came up the third generation. These are the computerized sizing and humerus and the head. And they were so useful because of the computer data that were available to us, that they influence the concept of underlying anatomic reconstruction of the proximal humerus. So this is what it looks like. You can actually template the shoulder and the humeral component. I'll be going into this in detail towards the end of the presentation when I'm talking about the recent advances. So another variation that the present prosthesis has is the variability in the lateralization or medialization of the humeral component and the glenoid component. So you can either have a medial glenoid and humerus, you can have a medial lateral glenoid and humerus, you can have a lateral medial or a lateral also. So various permutations and combinations we can have depending on the modularity that we've achieved. Coming to the anatomical and biomechanical considerations, it's like a jigsaw puzzle. You have to either recreate the original head retroversion, head inclination, medial posterior offset, depth identical to that of the natal femoral head. Then we have the individual lever arms of the rotator cuff also to worry about. So a lot of measurements and calculations have to go into each of these shoulder arthroplasty cases. Some of them, which are in the left figure, you can see the HT, which is the humeral thickness, which is the thickness between the anatomical neck and the parallel tangent drawn towards the tip of the humerus. That's this white dotted line. Then you have the inclination angle, which is defined as the angle between the head axis P1 and the proximal humerus shaft axis, which is also the blue angle that you can see here, neck shaft angle almost. So that is found to be normally around 135. Then we have in the B figure, you have the alpha angle. Alpha angle is the retroversion angle of the humerus. That is basically the normal to the humeral articular surface and the angle it makes with the transepicondylar axis. This is the superimposed transepicondylar axis, the same axis that has been brought here. And the angle between these two lines are the alpha angle or the humeral retroversion angle. Then we have the glenoid version angle, which is the angle formed by the perpendicular to this plane of the scapula and the glenoid face. That is the beta angle that is mentioned over here. Then we have the critical shoulder angle, or that is the angle between the glenoid face and the lateralmost tip of the acromion. Increasing CSA shows that there is an increasing likelihood for the implant to undergo impingement when it goes beyond 90 degrees of abduction. That is because the GT has a high likelihood of coming and hitting on the acromion. So it has another angle is the GTA angle, which is defined as the angle formed between the line connecting the top of the humeral head and the line connecting the top of the GT. These two with the humeral shaft axis. That shows how much the GT has to be adjusted with relation to the positioning of the implant. So these are just some of the measurements that have to be taken into calculation. Also, while calculating the head component for ATSA, you have to know which is the best fitting radius of the humerus head, because in a normal non-arthritic humeral head has a normal measurement of 46 plus minus 5 mm. However, in an osteoarthritic head, the size varies from 59 plus minus 9 mm. So it has flattened out. It has grossly malformed. So each of these components have to be taken into consideration while choosing the prosthesis that has to be seated in the humerus or in the glenoid. Also, another thing is the global offset. That is the axis, that is the distance between the actual center and the center where you have to start your reaming processes. That is the posterior offset that is there, as well as the medial offset. So these are all the measurements that have to be meticulously calculated, including the retroversion angle that we've already mentioned. So another thing about biomechanics is this is a normal way in which the biomechanics of ATSA works, or the normal shoulder also works. So when you start abduction, what happens? The supraspinatus pulls it medially and locks the head in position. So that is initiating the abduction. At the same time, subscap pulls it anteriorly and inferiorly in this direction, in the anterior plane. And posteriorly, the teres spina and the infraspinatus pulls it posteriorly and inferiorly. So these three muscles basically lock the head in place. And at the same time, that is when the deltoid starts with its mechanism of pulling it up. Now, since it's locked because of these three rotator cuff muscles, the pull of the deltoid creates a shear and over here. So pulling it upwards. And that shear, because of these three force vectors, gets compressed in, that gets converted into a compressive force that presses the head more into its place. And the lever arm where the deltoid attaches over here pulls the arm outwards, creating the movement of abduction. That is the overall biomechanism of how abduction works out. And that is exactly how ATSA tries to mirror the mechanism of the shoulder joint. Another thing that we've already discussed is the possibility of overstuffing in case the measurements are taken wrongly and the head component is taken larger than the native head. While doing the ATSA, it was commonly noticed that glenoid loosening is the main complication leading to ATSA failure. The same radius of the glenoid and the humeral head leads to good stability, but the problem is it increases the peak contact pressure. So because of these two components playing on each other, it is almost like having a knee joint without the meniscus. The contact pressure at the point of contact where there is transfer of pressures is very minuscule and creates a lot of wear on the poly. So what they decided was to mismatch the radius of the humeral component as well as the glenoid component, so that at any point of time, the contact area is not a very minuscule point, but it's site of a broader oval. So how much of this mismatch can be acceptable? So in this paper here, they said that best case scenarios is seen in case of 4 to 8 mm of mismatch between the glenoid and the humeral head. But this has a problem of its own called the rocking horse. That will be that I'll come into detail in some time. So what is indications and contraindications for anatomical total shoulder? Indications can be shoulder arthropathy, loss of strength, loss of mobility, pain, especially at night. These are the things that the patient will tell you. So clinically, we come across primary OA and in some cases secondary OA caused mainly because of instability or osteonecrosis or inflammatory joint disease. In previous times, complex proximal humerus fractures was also included as a indication for ATSA. However, in recent times, it has been understood that ATSA is not the ideal choice for a proximal humerus fracture, especially the complex ones, type 3, type 4 knees and all. So we'll come into that also. What are the contraindications? Obviously, if there is a soft tissue irreparable condition that is present in the joint, because the rotator cuff muscles are mandatory, it has to be functioning appropriately for the ATSA to function. Then if there is a severe posterior glenoid insufficiency, like the Walsh classification, biconcave glenoid and all, if that is the case, then it is best not to go ahead with the ATSA. Things to look for before deciding on the ATSA, you have to have a functioning rotator cuff. That is mandatory. You have to have this so that the biomechanism of the implant can work out. Then second thing is glenoid depth. You have to have a good glenoid depth of at least 15 mm or even more, so that the glenoid loosening does not come into play at least for next 5 to 10 years. Coming to the glenoid component, like I said, the reaming of the glenoid is essential in total shoulder anatomical total shoulder arthroplasty. The central axis of the glenoid and the version must be precisely and meticulously calculated. Restoration of the glenoid arc is mandatory for achieving rotator cuff balance, deltoid force, and joint stability. Now, what is this rocking horse that we were talking about previously? You said that there was a mismatch between the radius and the glenoid component. So what happens is that now it's not exactly a perfect sphere sitting on a perfect socket of exact same radius. There is a little bit of play. So instead of just the humeral head rotating in its place, it acts like a rocking horse. Basically, not only rotating, but also there's a slight amount of translation. So what happens in this case is that in the anterior and the posterior rim, there is excessive loading. So during rotation, it starts transferring from the anterior rim, goes all the way through the face of the glenoid and comes to the posterior rim and creates a increased in the force that acts on the rims basically. And that creates a possibility for acceleration of glenoid loosening. So coming to another problem that we discussed is the retroversion, glenoid retroversion or the biconcave glenoid as seen in this Walsh classification here. What happens here is that if the retroversion is more than 10%, 10 degrees, then the posterior rim loading is exponentially increased. There is increased stress in the posterior bone metals interface. There is increased posterior translation of the humeral head, and the force vector that is created by the functioning rotator cuff will be directed more towards the anomalous posterior direction and causes glenoid wear and loosening also earlier. So what are the corrections? What are the countermeasures that we have developed? So in case of excessive posterior retroversion, what we can do is there is anterior glenoid reaming. So to balance out that retroversion. Another thing that we can do is glenoid component with a metal augment. So wherever there is a deficiency, you put a metal component or a biological component like a bone graft, like a cancellous bone graft. And also in there are some papers that suggest facial material or muscle tissue or some component in order to fill the defect. So what about fracture arthroplasty? Main problem when in cases of complex proximal humerus fractures, they encountered is a non-union or the resorption of the head or the displacement of the fracture fragments. So in complex fractures, some research even state that hemiarthroplasty, like I said previously, earlier complex fractures used to be an indication, but recently hemi has actually overtaken the prevalence of ATSA in cases of complex fracture arthroplasty. And that also has been further overtaken by RTSA. We'll come into that. And another indicator for shoulder hemi is when the AVN, avascular necrosis of the humeral head, seems inevitable in complex fractures. As long as the glenoid cartilage wear hasn't developed, hemiarthroplasty in shoulder has been shown to be a good option, better than ATSA. So how do we know that AVN is going to set in? There is a common Hurtle's criteria that I'm sure everyone knows. Just a small revision. Hurtle's criteria is when you have a disruption of the medial hinge or less than 8 mm of the calca attached to the articular segment, increased fracture complexity, displacement of the fragments more than 10 mm, and angulation more than 45 degrees. Now, results and complications. ATSA has a very good result when handling glenoid OA, osteonecrosis of the humeral head, or inflammatory OA pathologies. In case of complex fractures, it has a very unpredictable result. Overall revisions in ATSA compared to hemiarthroplasty is 7:13. And overall complications that we see in ATSA compared to hemiarthroplasty is 12:8. So in some cases, they are good. In some others, we have got better options like the hemi or the reverse shoulder. So of these complications, the loosening of the glenoid component is the most prevalent. Then we have periprosthetic fractures, also stress fractures like the acromion fractures or the glenoid component wear fractures. Then we have infections and instability and rotator cuff lesions, especially in cases like overstuffing and if the subscap is not appropriately repaired post-surgery. So all these problems are also noticed. So in response to all these shortcomings and shortfalls, we have this silver bullet, the magic bullet here, that is the reverse total shoulder. It was first developed due to the unsatisfactory outcomes post-anatomical total shoulder for majority of the secondary degenerative shoulder conditions and complex proximal humerus fractures. So it can be seen in traumatic cases, degenerative glenohumeral disease, and in irreparable cuff tears. And it has got an excellent survivorship of around 95% in 10 years. So these are some of the details that we have compared to the recent literature. It was first developed in 1970 by Beddoe and Alloy. And the first modification was brought about by Gramont et al. In 1987. His design was called the trumpet. trumpet design. And the initial model was based on the knee system itself. That glenosphere concept had not come in at that point of time. Later on only, it advanced and modified and evolved into a semi-constrained prosthesis and using the glenosphere concept and using a specific technique called the contraction compression mechanism. So basically here, what happens is that this is the normal center of rotation. That's the center of the humeral head. However, in RTSA, what happens is that we have medialized as well as inferiorized the center of the rotation. So what is the advantage in that? There are multiple advantages. That is, medially displaced deltoid works on a longer lever arm due to this modification. So torque formula is basically force into the lever arm. So when we are increasing the lever arm, the resultant torque will be much lesser for resultant torque will be much more for the same amount of force applied. To make it simple, just think of an Allen key. If you try to rotate the screw using the short lever arm, it's very difficult. But at the same time, if you try to rotate the screw using a longer lever arm, it becomes much more easier. The same principle holds true here. So if you are lengthening the lever arm, the force you need to start or carry out abduction in the shoulder joint using the deltoid muscle will be, the force needed will be much less. So another thing is we have inferiorly displaced the deltoid also, which increasing the deltoid tension. So any of the plasty fellows can also understand that if we appropriately tighten the gluteus medius post THR or hemi, we can appropriately get the force to act on it. If not, the patient will come back with a post operative limp if the appropriate tension on the gluteus medius has not been reapplied. So exactly like that, if the tensioning on the deltoid is appropriately achieved, you can get the maximum out of the resultant deltoid. Another factor is by medializing the center of rotation, the amount of deltoid that can be recruited. This was the original center of rotation. And at that case, the deltoid fibers acting on the shoulder was only this much. If you medialize the center of rotation here, the resulting deltoid fibers that can be recruited for shoulder function is this much. But it has a small problem. It decreases the amount of deltoid fibers that is available for external rotation. So posterior 1/3 deltoid fibers are also responsible for a little bit of external rotation as well. And if you see these patients who have undergone RTSA, because of the medialization of the center of rotation and increased recruiting of the anterior, middle, and some part of the posterior also for abduction, the external rotation function is mainly lacking. So this is one prevalent complaint that many people who have undergone the RTSA arthroplasties have in common. What are the advantages? Just like the ATSA, the majority of the shear forces created by the deltoid is converted to compressive forces, creating a stable implant. It creates a rotational moment that allows the deltoid muscle to start abduction. So because of the medialization, the deltoid lever arm is improved. That force needed to start on the abduction is much less. Then we have a surface area increase, increasing the shoulder stability and potential range of movement. Indications and contraindications. It's a rotator cuff arthropathy. Arthropathy is the main indication, which is unable to be managed with ATSA because of the non-functional rotator cuff. It has improved range of motion, forward flexion and abduction, and has got 10-year survival of about 95%, and complication rate remains slightly on the higher side of 17.5, but comparatively better than the ATSA and Hemi. Second indication is massive irreparable cuff tears. As I mentioned previously, cuff is mandatorily required for ATSA. If it is not available or if it is not functioning properly, ATSA is out of the question. So in that case, RTSA comes into play, and it has got an excellent survival rate of 90% in 10 years and improved functional and motion scores. The third indication is the complex proximal humerus fractures, like the 3-part or the 4-part. So in proximal humerus fracture management with RTSA, it has been found to increase in popularity from 3 to 24%. So when we are looking at ATSA, we found that hemiarthroplasty already overtook ATSA in management of complex proximal humerus fractures. At present, RTSA has overtaken hemiarthroplasty also, and this happened way back in 2016. So it provides improved function, motion, pain scores, and revision rate. Also, it is found to be good for patients with severe bone loss due to primary glenohumeral arthritis, tumor, or inflammatory arthritis. So in case of revision also, RTSA is found to be an excellent option in case of a failed hemi or even an ATSA. Another thing is tumor. In cases of tumor, what we require is ideally we have to go for a radical resection of all the tumor tissues. A lot of structural integrity will be lost. And in those cases, to regain the shoulder motion, the best option is to go for a RTSA. So this gives us an option in tumor cases as well. And some of the other indications are post-traumatic glenohumeral arthritis, chronic irreducible shoulder dislocation, and inflammatory pathologies. So where do we not think of RTSA at all? Obviously, if the deltoid is compromised. Where can the deltoid be compromised? If there is an axillary nerve palsy, if there is a deficient deltoid muscle, if there is an active infection, obviously you don't go for a joint replacement in that case. Significant glenoid bone stock deficiency, which cannot be filled even with biological or structural component fixation. If there is a skeletal immaturity or if there is a neuromuscular disorder. So what are some of the complications? It can be like mentioned earlier, process infection, process instability, axillary nerve palsy due to extensive dissection. There's something called as a notching that is clearly visible only in the RTSA cases that we'll be talking about. Then there is base plate failure, exactly like the rocking horse and all those problems that can happen here as well. Then there is periprosthetic fracture. Like I said, the stress fracture when the shoulder abducts and hits on the acromion can cause acromial fractures or the glenoid fractures due to excessive notching. Then there is vascular injury or heterotrophic ossification. So coming to the biomechanics, like I said, it was developed to mitigate the difficulties of managing arthritis and cuff deficient shoulders. Initially, it was in a monoblock design, which got modified into this, and it plays on the medialization of the center of rotation and the retensioning of deltoid with constant centers of rotation leading to a stable implant. It is also a semi-constrained implant, which gives us a larger arc of motion, and it helps by decreasing the shear force and converting more of the compressive force. So the resultant force vector will be shifted from this angle to this angle, which will permit the deltoid to start on the abduction. So this is another concept that we've already discussed. More of the deltoid will be recruited, but the resultant problem is that external rotation in these cases will be decreased. This is again lengthening and tensioning of the lever arm that will enable more deltoid fibers to be oriented in this vertical axis and more deltoid fibers to be recruited for the function. So this surgery gives approximately 20 to 42% increase in the deltoid momentum. So the force required to start on the deltoid motion will be much less. Like I mentioned, this is the double-edged sword. The problem with increasing the deltoid recruitment is that the posterior one-third of the deltoid that acts as the external rotator also is compromised. So this is a very common complaint that comes across from these patients when they come for follow-up. These are the advantages. The shear force is minimized and increased stability. The RTSA is considered to be 3 times more stable than the ATSA, and in position of 90 degrees of abduction, it is even considered to be 5 times more stable than the native original shoulder. Even though we all know that the native shoulder is the best overall, in certain positions, especially at 90 degrees abduction, it has been shown that RTSA is the most stable joint. And it works on the contraction compression model. It is a semi-constrained processes that helps give us the larger arc of motion. The humeral cup, where do we position that? The positioning must be deep enough to allow the inherent stability in a cuff deficient shoulder, and it has to be shallow enough to minimize impingement and at the extremes of movement. And how has this modified over time? The design modifications have come in various packages involving the glenoid base plate as well as the humeral component. The glenoid base plate has undergone medialization, which decreases the shear force of the deltoid and increase the compression forces. And it has also its disadvantage, like increasing chance of impingement at the subacromial level, increasing chance of notching at the subglenoid level, and decreased external rotation due to the unavailability of posterior one-third of deltoid to carry out this function. So what are the countermeasures? So in order to counter these problems, they proceeded to move into a semi-constrained implant from a highly constrained implant. That is one important modification that they had undergone. And also, in order to prevent notching, the inferior placement and inferior tilt of the glenosphere, and also including a overhang where the glenosphere hangs beyond the inferior border of the glenoid, is also introduced. That helps to avoid notching. And first modification was that of an implant called as a delta implant that was found to be extremely useful, but it had its own share of complications. Complications such as excessive notching, as you can see here. The medial component of the humeral cup in abduction kept on hitting on the glenoid inferior border, creating this problem called as a notching. The another problem that was found was that because of the loosening, the entire force was converted into the implant, and commonly we found that these screws would break off, not able to handle the force and the pressure. So revision surgeries involving plating of these glenoid and refixing of the glenoid component was common. And also heterotrophic ossifications was found to be very high in association with the resorption of the greater tuberosity area here. So these are the countermeasures. So in order to counter these, what they did was they reduced the neck shaft angle so that the neck notching risk was found to be less. So instead of 155 that was present in the initial delta implant, the neck shaft angle was brought down to around 135 to 145 in a range. And each of lateralization and inferiorization gave an additional 5 degrees each in adduction plane. So what is this notching? Servo classified notching as grade 1, 2, 3, 4. One is where the medial part of the humeral component comes and hitches on the inferior border. This 2 is where the hitching happens and it involves the inferior screw as well. Grade 3 is where the whole of the inferior screw is involved. And grade 4, the notching is so severe that it has gone through the inferior screw and involved the central peg as well. In that case, absolutely high chance that the remaining screw will break off and there'll be a need for a repeat surgery. So countermeasures for avoiding notching: inferior placement with more than 3.5 mm of overhang was found to prevent notching, and inferior placed glenoid associated with a better range of motion in abduction and adduction. Another problem that was encountered was the stress fractures on the acromion, especially in the shortening of rotator cuffs, and in abduction, the greater tuberosity area was found to hitch onto the acromion and cause fractures at those places. So what was the modification that was designed? So the design was in part increased. The amount of medialization was found to be too much. So they decided to lateralize it slowly. So as you can see here, through time, they found that it was better to increase the size of the glenosphere to the present level where it involves 2 by 3, that is 2/3 of a sphere. So the current glenosphere has a structural integrity of 2/3 of a initial sphere. And the humeral component also underwent modification where the poly was found to be best in an inlay versus onlay technique. Onlay has a thicker poly that helps in slight lateralization. Inlay has a thinner poly that keeps the humeral process medialized. So thanks to these permutational combinations, like mentioned earlier, we have a variety of uh, prosthetic options that we can have, either a medial humerus glenoid, or a lateral medial glenoid humerus, or a medial lateral glenoid humerus, or in case of an onlay with a lateralized glenoid, we can have a lateral glenoid or lateral humerus. This is very rarely used. Most commonly used are these two. So the problem with the medial is that the original tension of the rotator cuff, as you can see here, is rarely gotten. So the stretch on the rotator cuff is very less. So the function of the rotator cuff that can be carried out in case of a medial humerus and a glenoid is problematic. So the best is to either go with a lateral glenoid medial humerus or a medial glenoid lateral humerus. So very quickly, very briefly going through the procedure, usually we take the deltopectoral approach. You see the affected glenoid and the humeral head. You take the humeral cut, after which you broach the humerus for the appropriate size. Take the glenoid cut as well, central peg drilled, and the base plate is fixed using the 4 screws, and the glenosphere is attached, following which the humeral component is placed. So this is a very, very brief view. before I end it, I just wanted to show you the latest surgery that is being done. So this is the latest advances. This is called a GPS oriented surgery. So in this case, you actually have the CT scan fed into this computer software, and you can template the glenoid and the humeral head component as shown thus for varying positions. So this is the deltopectoral approach, and the tracker. This is the tracker that gives the instrumentation and the computer software a GPS 3-dimensional overview. And this is attached to the coracoid, screwed into the coracoid. So once the placement and everything is done, you can simultaneously make the cuts as well as visualize exactly where your drill is going. So this is the central peg being drilled into the glenoid, and you can see as you ream how your reaming process is going and how the end result of the glenoid base plate will be sitting. So this is the yellow, that is the instrumentation, and this is the desired position of the glenoid. So with each angle up or down, you can see this modifying into the final result. So whichever result you want to achieve, you focus on that and continue with the reaming. So exactly like this, the central peg hole is being drilled. This is the small base plate being inserted into the glenoid component. And here also, exactly when you drill the screw holes, you can actually see your instrument going and the trajectory of the screw as well in both the axial as well as the coronal cuts. And also, you don't have to constantly keep measuring. See, the drill bit here itself has color coded this thing for different depths. So where you find the second cortex resistance, note down the color. And when you get the final push through, you can remember the color and then put the appropriate screw. So it saves time as well. So this is the glenoid base plate being fixed with the multiple screws, and the glenosphere being attached with the final fixation screw. This is the humeral head, which, as you can see, is osteoarthritic and deformed, being expressed out. This does not have multiple reamings or anything. It just has a broach system, humeral component. So you broach it and you trial it with the different sizes. And this is the poly going in and being reduced. Before you finally reduce it, you make sure that you take enough stitches through the bone for reattachment of the subscap. That is extremely important. Subscap repair, it is still a very, very controversial topic of discussion, but all doctors agree that if it is a possibility to repair the rotator cuff prior to closure, please do so. We don't want that to be, free floating in the shoulder. And it also has an additional benefit: the dead space is reduced if you repair the subscap. And this is the humeral component, the final humeral component. You can see the onlay poly with a porous coating proximal humerus. And finally, closure after repair of rotator cuff. Thank you. I'm aware that I had to rush through a bit. It was a very vast topic. And if anyone has questions, please.
Thanks, Ashok. Actually, your presentation was quite precise. This is what is expected. And there are many things to be discussed on reverse shoulder arthroplasty, on the incidence of failure and different set of patients who undergo the reverse shoulder. Say, for example, we have to differentiate them according to the type of pathology, whether it is an osteoarthritic shoulder or rheumatoid shoulder, and what is the incidence and the survival rate. So many factors have to be discussed, but it's all it just goes overhead once you try to do it in one class.
Yes,
but
sir.
the basic principles about the shoulder arthroplasty is, it is the biomechanics is totally different for a total shoulder, whereas it is completely different for a reverse shoulder. Doing an anatomical total shoulder arthroplasty is possible only in one scenario, which is osteoarthritis. Okay. Apart from that, any other cases, let it be a proximal humerus fracture, or it can be even in case of rheumatoid shoulders or other cases, doing an anatomical shoulder is very, very difficult.
Yes,
The main
sir.
reason is because of balance of soft tissue coupling. In rheumatoid shoulders, you don't have a good balancing of the cuff tissues, and in other conditions, when the GT, for example, in case of proximal humerus fracture, the GT is not oriented properly, then it is never an anatomical
Yes, sir.
condition. So it's just a total shoulder arthroplasty. The most commonest reason for failure in shoulder replacement is not in the humeral side, it is at the glenoid.
Yes,
So
sir.
that's because of the small bone stock which is present, and we have to be very careful in preoperative assessment of the glenoid vault. You mentioned it as glenoid depth. It is actually the glenoid vault. The
Okay, sir.
glenoid vault should ideally be more than 15 millimeters. Anything less than 15 millimeters, it is an indication for increasing the bony offset. That is called bio RSA. Or you need to do some supplementary grafting in such cases,
Yes, sir.
or you may have to use some augments. The problem with shoulder replacement here is it is not enormously studied like how it has been done for the total knee or total hip, where you see the survivorship is more than 20 or 25 years.
Yes,
The
sir.
reason is it's emerging. Maybe in another 10 years, we'll get a detailed study from various centers on which processes survives a lot. In India, there are 4 processes which are available. One is from the Arthrex Eclipse, then from the Tornia, then we have from the Evolutus, and then we have from the Permedica, that is Exactech, which was previously called, and even
Mhm.
Depu.
Yes, sir. Yes,
And
sir.
we should be oriented with different processes, designs, because their concepts are totally different. But one thing which is universally accepted, whether it doesn't matter whether you use different implants or not, a few things should not be bypassed. One is you need to have an excellent exposure of the glenoid. As far as the surgical technique is concerned, the exposure is very, very important. And Sumant Krishnan's antro-superior approach gives us a fantastic exposure of the glenoid. Okay.
Yes, sir.
So,
Yes.
irrespective of whether you're doing a total shoulder or reverse shoulder, an antro-superior approach is less invasive compared to the deltopectoral and gives you a good hold or orientation to the glenoid and helps in proper placement of the glenoid component.
Yes,
Now,
sir.
the most important problem that we experience with the glenoid is disorientation. We have no idea where is the center of the glenoid vault or how to correct the version. You have mentioned the use of GPS. Definitely, this is one procedure which definitely needs GPS assistance for
Mhm.
us to optimize the fixation of the implant in the glenoid, because this is a very small bone, and if
Yes,
you
sir.
just deviate by 1 or 2 degrees, there will be a significant component malposition, and which is the most important source for failure. That's the reason GPS is very important. And if it is added to the patient's cost, it will cost another 1.5 lakhs for the surgery. As such, the processes itself is approximately 2 lakhs. And the cost of GPS will add on to its the expense, which will be additional 1.5 lakhs. So there is one doctor by name Professor, I forgot his name. He's in France, he's in Paris. He has devised something called as a glenoid positioning guide. It's called GPG, which is something like using a pointed reduction forceps and fixing it on the anterior and posterior side of the glenoid, and that will give us actually the central position of the glenoid, irrespective of the version. So this GPG, you can type it in the Google, you will see it. This GPG guide is very, very useful and cost effective in fixing the glenoid peg exactly in the center of the glenoid, and helps us in optimizing the fixation. Now, more than 15 degrees of version, either antroversion or retroversion, more than 15 degrees is not a good indication for eccentric reaming. And that is where we may have to use the augments, and various augments are available. And you have to prepare prior to the surgery. Bony increase offset, excellent survivorship. You have
Mhm.
seen Pascal Bolo showing everything about bony increase offset, but
Mhm.
you have to make sure that you have adequate, no, you have determined the offset preoperatively, and intraoperatively you are increasing the offset adequately, because it should not cause overtension of the deltoid. That is very, very important.
Yes, sir.
Now, respecting the deltoid is very important, and people think that the antro-superior approach actually hampers the deltoid healing. It is not so, because you're just elevating it from the anterior corner of the clavicle, and when you manage to suture it back effectively, the deltoid heals very well. So that there is no issues about the deltoid healing. But whether to increase the lateral offset, whether you have to lateralize the humeral component, whether you have to medialize the glenoid component is where the implant design matters. Some implants, for example, the Arthrex and the Depu, advise on inferior placement of the glenosphere in a reverse shoulder arthroplasty, because
Mhm.
to prevent scapular notching.
Yes, sir.
Whereas other implants like the Evolutus do not worry about that, because their design is such a way that you have to just put the glenosphere exactly in line with the inferior border of the glenoid, and scapular notching does not occur. The surgical technique plays a very, very important role. And we have to be extremely cautious in advising which patient needs arthroplasty, because they're going to come back to you after 10, 15 years, and you're left with nothing in case of a
Mhm.
reverse shoulder.
Yes, sir.
And we have to be extremely cautious. Total shoulder, on the other hand, is definitely a much more easier procedure compared to reverse shoulder. Very easy. But the problem is, if you do not optimize the rotator cuff balance, then it's going to fail pretty soon. All right. So we have to be very careful in retensioning the rotator cuff, as well as maintaining the anterior and posterior post couples to an optimal position. Uh, See, in our setup, we have not done many total shoulders because of the maybe because the patients are not aware of the situation, or we have not got the correct indications for surgery. But always be prepared for a revision in case of a total shoulder that will happen in another 10 to 15 years. So
Yes.
you have to use something called the platform stem. You know what is platform stem? You just put the stem inside and you put the glenoid base plate. In case the patient comes for a revision, all that you have to do is change the poly. Open up,
Oh,
change the poly, make the glenosphere, make the base plate, glenoid base plate into glenosphere, and make the humeral stem. Without removing the humeral stem, you can make it as the cup. So that option is available in all the companies, but I would definitely prefer the Evolutus and the Permedica system, which are quite easy. So generally, we have to be very careful about three most important things when you're coming across a patient of who needs a who needs arthroplasty, not just reverse arthroplasty. First, importance to the rotator cuff balancing and the integrity of the deltoid
yes, sir.
in a total shoulder arthroplasty. Then second thing is proper placement of the glenoid component both in reverse as well as the total shoulder. That is the epitome that has to be done properly.
Yes, sir.
Third most important thing is a proper and structured rehabilitation, because you're just putting the processes inside, and if you do not condition the muscles, if you don't train the muscles accordingly, then you're going to have a very tough time. And that's where the rehabilitation plays a very, very important role. So what we'll do right now is we'll discuss about the physiotherapy, the rehabilitation for total and reverse shoulder right now. And then if we have time for the tendon transfers, we'll do it. Otherwise, we'll do the tendon transfer next week. Because if we do a tendon transfer right now, then we are mixing two concepts and we'll get confused. Let's
Yes, sir.
proceed to the rehabilitation of the arthroplasty right now.
Okay, sir.
Okay. The physios are not ready for the talk.
So Ganeshan sir is aware. I think he's having trouble connecting. I'm calling him, sir.
Sir, I'm just there, sir.
Okay, okay.
Am I audible?
Yeah, you're audible, but not able to see your presentation.
Sir, now am I visible in the screen?
Yes, Ganesan.
Good morning, sir. My talk is on the shoulder arthroplasty rehab. So this is a paper in 2015 where they just did a study on the outcome comparison on the patients of arthroplasty and reverse arthroplasty, where they were looking at the outcome in terms of complications, and in this the majority of the complications were related to the acute postoperative pain, which in both the groups were higher. And the study said that the overall outcome at 2 years is good, comparing the reverse as well as the total shoulder arthroplasty. And in this paper in the Journal of Shoulder and Elbow Surgery, the paper had what are the outcome measures they had taken is one is the pain score. This is a 2 years follow-up of the patients where they said the complications were pretty much equal or within the limit, but the outcome scores were the visual analog scale, the goniometric measurements for the pain, and they had plain radiographs taken to look at the scapular notching. And at the 2 years, there was no major difference in the complications. And the outcomes by the visual analog scale was pretty much similar. Only thing was the external rotation deficit was higher on the reverse compared to the total shoulder arthroplasty patient. And this in article in 2020, where they have done a critical analysis on the reverse shoulder arthroplasty rehabilitation protocols, which is available on the net. So they had two studies, one in 2010 and 2016 by Mulir et al. And Denar Ladman. Now, in this two, they had a delayed protocol and as well as a immediate motion protocol. So the immobilization period was around 4 weeks in the 2016 paper by Renat, whereas in the 2010, the immobilization period was about 6 weeks, and in the delayed protocol, the immobilization period was up to 8 weeks. And the range of motion was initiated with passive range of motion and further progress to active range of motion only by the 2 months time. The important things to discuss in terms of shoulder immobilization was that none of the papers or any of the literatures were having a good consensus on regarding the utilization of the shoulder immobilization. And while universally the shoulder total shoulder arthroplasty supported the use of an immobilization, but the duration again was not recommended anywhere or coming to a consensus. The patients have been, studies have been recommending either using a simple sling immobilizer or even an adduction sling, which has been recommended. Now, majority, there are reports in the literature which supports for a 4 to 6 period of immobilization for the reverse shoulder arthroplasty. But whereas for the total shoulder arthroplasty, there is not much specific recommendation. While what they recommend and say is that most of the time it is immobilization is to eliminate instability at the early stage, but majority of the instability is happening with the atraumatic in nature, and they are not sure whether it is actually going to help them in preventing the dislocation in the initial phase. Range of motion, there are several factors which influence the shoulder range of motion. It primarily depends upon the repair if it is done for the subscap and to prevent the help in the healing. And there is substantial disagreement in the literature report, which is in terms of the passive range of motion and the delayed passive range of motion. Majority of the studies have reported where they want to delay the initiation of the passive range of motion at least for a week, and there also has majority of them citing that they want to start the active range of motion as early as 4 weeks post arthroplasty. Strengthening program. So we have to remember that when a reverse shoulder arthroplasty is done, the shoulder biomechanics is completely altered, and it is heavily dependent on the deltoid and the periscapular muscle function. Whereas in the total shoulder arthroplasty, the biomechanics is try to maintain as much as possible. So there is going to be an altered scapulohumeral rhythm and decreased scapulohumeral elevation, and the dependence on deltoid and the upper trapezius is going to be more heavily relied on the shoulder abduction. So the paper suggests that the importance of deltoid function uh, is very important, and people who have large size deltoid and less fatty infiltration have a better strength chance of having a good functional outcome. And trying to work on an exercise program for the scapulothoracic and deltoid rehabilitation in reverse shoulder arthroplasty can help them have a better functional outcome. And for strength training, most of the studies indicate to wait up to 8 weeks to start any strength training programs. This is in terms of the tendon transfer. So we have in Ortho also few tendon transfer cases what has been done. So the idea here in this papers have been the arm to be immobilized at 30-degree abduction and 30-degree external rotation. So most of the papers are recommending that they try and have the arm at a 30-degree abduction. Now, coming on to the passive, initially they say that it has to be done with the help of the therapist, where the external rotation movement is done with the help of the therapist passively, then progress to active assistant. So it is basically trying to make a new movement learning by the latissimus dorsi. And there was one study where they indicated that using a biofeedback based rehabilitation, and this again is starting only at the third month, 12 weeks post-op. And the paper suggests that most of these patients will be able to get better only by 6 months to 1 year, until where they can have some amount of good external rotation progression. This was again a paper that was published by Joe Spiti in 2005, where they recommended a post-op rehabilitation protocol. But comparing to the current literature, this is changed a lot. So the rehabilitation protocol should not only just be based on the clinical criteria, but it has to be also collaborated with the surgeon to know the soft tissue status at the time of surgery, and based on that we can do. There's a recommendation in this paper where they recommend to use the shoulder pain and disability index score to plan guiding how to progress the exercise. So these are questions related to pain and disability, that functionally what they are able to do. So the criteria should be that if they are able to do with less pain and less discomfort, we just try to progress to the next stage. The use of cryotherapy has been recommended in this paper in 2018, where they say that you can use cryotherapy extensively post surgery, which can help in the pain management. And the post-op for the reverse shoulder has to be first to be discussed with the surgeon, and the physios have to communicate to know what will be the immobilization period and the status, so we can have a timeline to see when to start, particularly the passive and the active range of motion, so that the patient is also educated on that, that until then this is what the rehab is to be expected. So these are again some of the papers which shows how the range of motion. So you can see that most of the papers recommend that they will be able to achieve 90 degree of shoulder post-operative range. So what are the reasons why we sometimes have to slow down on the protocol is on the deficiency in the posterior cuff. So they can have a positive extension lag, abnormal scapula control. Sometimes the patient has been having an abnormal scapular control even before the surgery for a very long period. And then now to try and get the exercise back is difficult. Any additional concomitant procedures are done. If there is any neural deficit in terms of axillary, long thoracic or spinal accessory, and they can be helped with good counseling, maybe hydrotherapy for regaining mobility and having pain control. Occupational therapy is to get their daily routine work done. And this is another systemic review where they had about 16 studies which met the criteria, and they all had only a level 1 evidence. So again, this is also a paper where the arm sling was recommended for a duration from 3 to 8 weeks time, and the principles of loading of exercise and the consistency about the exercise were based on whether it is a total shoulder or the reverse shoulder. So this is a program what we give to our patients. So the initial period is of immobilization, and we allow finger, wrist, elbow, and cervical mobility. And shoulder isometric exercises is basically used to maintain the property and the activation of the muscle. So this is also recommended as in the reverse shoulder arthroplasty to perform the deltoid activation as much as possible, because if the patient is going to be immobilized for 6 weeks, then the deltoid can inhibit and shut down, which then again makes it very difficult to start the active range after the immobilization period. And we give instructions particularly to our patients that do not sit on a low sofa or chair, because then they, by mistake, they might put their hand down and press down. And then sometimes fear of pain, they tend to hold their shoulders very stiff, and try not to do any other exercises on their own, and the hygiene, how they have to maintain. So the phase 2 will be around 6 weeks for reverse shoulder, and maybe 2 to 4 weeks at shoulder arthroplasty, where we use the passive shoulder movements, which the patient does with self-assisted. So those will be using the good arm and then doing a flexion up to 90 degree. And this is at passive assisted movements using the wall ladder or the cane. So active range of motion can be the next stage, which can be maybe around 2 months in the total shoulder arthroplasty, and 3 months in the reverse shoulder arthroplasty. And strengthening exercises with minimum weights and bands can be started at the later stage, post 3 months. So criteria for discharge. So this was an article where I saw that when we can tell them they can discharge from exercise therapy. So patient is able to maintain a non-painful active range of motion. So if the patient has got no pain and can move at whatever range they are able to do, at least minimum 90 degree of shoulder abduction and flexion, then maximized functional use of upper kidney, able to do their ADLs without any discomfort, and the patient has got some amount of good strength, power, and endurance, and patient has returned to his routine lifestyle. So the take-home message: patient education, family members education on the key outcome of the surgery. Most of the patients at the older age have less understanding of the surgical procedure. So when they come for review, they either say that I'm still not able to lift it above, or they say that the surgery has done 3 months before, still I feel some pain. So if the family member are also educated, they can re-educate the patient at home regularly. Pre-surgery muscle status, particularly the activation of some of the scapular muscles, which has not been used, and dominance, whether we are doing the right shoulder or the left shoulder, so that will give us an idea about their activation. And initial immobilization, we have been using immobilizer. So as the literature says, arm sling or the abduction pillow. So we are now currently using the arm immobilizer and sometimes the arm sling. So the tailor-made protocol as per patient necessary. So we can now try and make the protocol where we can write when we want to start the passive, when we want to start the active assisted, and when we want to achieve the range. So we mark it in our chart for the patient saying, okay, this is the stage where only the flexion you have to go only up to this level, not more than that. So the cuff status will also predict the outcome of the function. And for these patients, I think if we can do a review every month up to 6 months, that will be better to know how they are functionally improving. Tendon transfer is again a challenge. We need to see to that the patient tries to achieve that external rotation at least by 3 months as an activation. Even minimum activation should be there. Thank you, sir.
Thank you, Ganesan. Actually, your presentation was indeed better. The few things which we need to do is you need to show us some videos of difficult cases where you managed to overcome with tailor-made protocols for those set of patients. We do have some patients with shoulder arthroplasty who initially had significant problem with elevation and rotation, and then right now almost like in 6 weeks or 2 months post op they are having a satisfactory range of motion. Maybe you can put up those videos. What I would like to suggest is let's come up with a rehabilitation guidelines for patients undergoing shoulder arthroplasty, and you have the literature review which you have presented here, which is more than enough. All we want to do is incorporate some videos of patients who underwent the physio and upload it in our Ortho Academy. So this will act as a source of rehabilitation guidelines for all the members. And already we are preparing for rehabilitation guidelines for instability patients. Let's prepare one for shoulder arthroplasty and upload it in the academy. One. Second thing is success of shoulder arthroplasty is not guaranteed unless and until the surgeon sits and discusses with the patient and prognosticates the patient. If the surgeon does not discuss about the expected outcome, then it is considered a failure because the patient's expectations are beyond imaginations. They think once the surgery is done, everything is normal. That should not be guaranteed to the patients, especially when you're doing reverse shoulder arthroplasty or even total shoulder. The problem with total shoulder arthroplasty is there is loss of proprioception, which means the patient does not have joint position sense. And there is a very high chance for the patients to do surgery in the wrong way. And that may lead to eccentric loading of the implant. And that may in turn lead to wear and tear and early failure. So we have to, as Ganesan had mentioned, preoperatively, we have to identify the scapular malposition, all factors which are responsible for improper shoulder rehab, correct it preoperatively, and then subject the patient to surgery. And then in future rehab, you have to make sure that it's maintained. That is absolutely crucial as far as total shoulders is concerned. The reverse shoulder is, on the contrary, it's a totally easy procedure for rehabilitation because you have to focus only on the deltoid. The deltoid has to fire. If the deltoid fires, the patient will get fantastic range of motion. There are some cases where we have to do tendon transfers. Example, to supplement the teres minor, we may have to do the lat dorsal transfer. And in such cases, the principles are same as what we do for a normal cuff repair with a tendon transfer. So that is a totally different entity. But for rehabilitation, we need current literature evidence, which you have already presented, and add on some of the videos which you have done for some of our patients, and try to upload it and come up with the rehabilitation guidelines in the academy.
Yes, sir. Sir, and the recommendation here about the arm sling and this one, I think for our patients also, we can also stick to just an arm sling rather than immobilizer, sir.
I mean, for patients who are undergoing replacements, I think it's better to go for arm sling rather than immobilizer, because arm sling is absolute immobilization is mandatory only in case of cuff repairs, not
Yes,
in
sir.
case of replacement. So we can switch over to arm slings.
Yes, sir.
Yeah.
please. Is that all for today? Any spine?
No, sir, we have one more presentation, sir, by Dr. Dharani. He's about to join, sir.
Yes, sir.
Oh,
Okay.
So can I start the presentation, sir? Good morning, sir. Today's my topic is about tendon transfer and superior capsular reconstruction in case of massive cuff tear. So role of tendon transfer in case of massive posterior-superior cuff tear, where supraspinatus, infraspinatus, or plus or minus teres minor tear. The options available are latissimus dorsi transfer, lower trapezius transfer, and episcopo, that is both LD and T major transfer. So principles of muscle transfers are the muscle that is transferred should have a similar line of pull and also similar extension, similar excursion, one transfer for one loss function, and the strength of the donor muscle should be normal, that is more than 4/5. Contraindication for the tendon transfer is pseudoparalytic shoulder, where there is complete subscapular tear and deltoid palsy, and also if the Amrad classification of more than 4/5 in case of glenohumeral arthritis. Coming to latissimus dorsi transfer, it is a big muscle from the dorsal aspect, originates from dorsal spine, lumbar spine, and iliac crest, and it turns around the teres major and inserts into the anterior humerus. It brings about the action of adduction, internal rotation, and retropulsion. So how it works? After a latissimus dorsi transfer, it stabilizes the humeral head and also it facilitates the action of the deltoid. And the most important contraindication for latissimus dorsi is deltoid palsy. So indication of LD transfer is in case of painful shoulder with irreparable cuff tear, that is posterior-superior cuff tear, atrophic muscles of gout layer of more than 2 fatty infiltration, limited active forward elevation with weakness of external rotation, and good deltoid muscle function, and also with no pseudoparalytic shoulder. So it was found that many literature, best results can be found in LD transfer in case of good subscapularis cuff tendon and if the teres minor is of no atrophy. So coming to surgical techniques, in semi-beach chair position, the incision should be at the posterior axillary line. And after that, we have to identify the tendinous latissimus dorsi distally. And coming to proximally, we can identify the plane where LD becomes a flap-like structure. We can find the plane between the teres major and latissimus dorsi. After that, we have to detach the latissimus dorsi from the proximal humerus, where we have to be cautious enough to protect the radial nerve. And at the distal end, we have to make a croquet suture at the distal end of the latissimus dorsi. Then after that, we have to find the plane anterior to the posterior deltoid. That is the plane where the tendon is passed through. Because of this highest excursion of latissimus dorsi, we can bring the latissimus dorsi tendon to the posterior aspect of the footprint. And after bringing the tendon up to the footprint, we can fix the latissimus dorsi with either double row or single row technique. And along with, we have to suture the tendon with the remaining cuff tissues, which add on to the effect. So regarding there is a biochemical study depending upon the level of tendon insertion. If the latissimus dorsi tendon is inserted at the level of the supraspinatus, it will restore the active elevation. Suppose if it is fixation at the level of the infraspinatus, then it will restore the along the forward elevation. External rotation is also restored. So if the latissimus dorsi is accompanied with the partial repair, which restores the couple forces, it is found that it has better mobility, strength, and functional score, and also it acts as a dynamic cuff augmentation. So next, coming to the lower trapezius transfer. It is used in case of irreparable posterior superior rotator cuff and also in case of paralytic shoulder to restore the active external rotation. It is found to be the ideal transfer option because it acts as a identical line of pull as infraspinatus, and also it originates from the cranial to latissimus dorsi and medial to the infraspinatus fossa. And also exertion and tension forces are very similar to the infraspinatus. EMG study also showed that synergetic external rotation activation. That coming to lower trapezius, trapezius muscle has three parts, that is upper fibers, middle fibers, and lower fibers. It acts to elevate, retract, and extend rotates through rotates the scapula. It originates from the C7 to T12 spinous process and also from the occiput, and insert at the lateral third of the posterior clavicle and medial acromion and also scapular spine. It's up to the spinal axillary nerve. So it was first LT transfer is first performed in 2007 and was described by 2009 by Hel Hassan for the traumatic complete brachial plexus injury with the help of the middle and lower trapezius transfer and also with the Achilles tendon allograft. So from where it was expanded to the rotator cuff deficiency for more superior lateral insertion and also acromial osteotomy. Further, it was refined to arthroscopic fixation by avoiding the acromial osteotomy. So lower trapezius transfer here, lower trapezius is found to have same line of pull compared to the rotator cuff, especially infraspinatus. And comparing the exertion of between trapezius and the infraspinatus, it was found that both trapezius and cuff muscles are comparable to each other, and you can see the latissimus dorsi is found to have highest exertion. So comparing the tension between the trapezius and rotator cuff, deltoid is found to be the highest tension, and on comparing trapezius and infraspinatus, both are comparable to each other. On carrying out the biomechanical study, in case of absent deltoid, it was found that in case of latissimus dorsi transfer, it tend to sublux the shoulder, whereas in case of lower trapezius transfer, the stability of the shoulder is increased. And also another biomechanical study, it was found that LT transfer provided more effective external rotation momentum when compared to the latissimus dorsi transfer. Another study, depending upon the momentum, in case of neutral position, on transferring the LD to the superior position of the greater tuberosity, it was found that latissimus lower trapezius transfer has better momentum than the latissimus dorsi transfer. Whereas in case of 90 degree of abduction, latissimus dorsi momentum is slightly better, but not significantly better than the LT transfer. And also lower trapezius transfer was better than LD transfer with regards to restoring the native glenohumeral kinematics and stability, and also joint reaction forces in 0 degree, 30 degree, and 60 degree of abduction. Whereas LT transfer also restores the compressive forces, and also LT provides better centering forces. Indications are subscapular tear up to level type 3, that is up to upper 2/3 of tear, not complete tear. In case of irreparable teres minus tear, and also proximal migration of humeral head with pseudoparalysis, where there is no active external rotation, and also shoulder arthritis up to type 2, and also in case of failed SCR. Since LT is found to have less excursion, it needs augmentation of graft in the form of allograft or autograft. The options available for graft augmentation is Achilles tendon allograft or dermal allograft, fascia of fascia lefta, fascia of infraspinatus muscle, and also semitendinous autograft. Coming to surgical technique, first in beach chair position, we have to make a small incision just 2 centimeters below the medial spine of the scapula. After which, we have to excise the fat pad over it, where we can able to find the tendon of the lower trapezius, and we have to detach the tendon from the spine and also the undersurface of the scapula, and we have to look for the excursion of the lower trapezius muscle. And after which, we have to incise the infraspinatus fossa, which gives the plane of tendon passage just beneath the lower trapezius. While detaching it, we have to be careful in detecting the spinal nerve, which comes 2 centimeters from the medial spine. After that, once the plane is created, just anterior to the deltoid muscle, one end of the allograft is suture is passed, and it is pulled through the lateral portal, and distal end of the allograft is stitched to the footprints of the cuff, whereas other and also we have to suture the first by medial suture and followed by lateral anchor, and also then we have to suture the tendon along with the remaining cuff tissues, whereas the medial end is attached to the distal end of the lower trapezius. And the distal end of the lower trapezius is tied by the help with the pulver trap technique, where the distal end is made into 2 limbs. One limb is inserted through the tendon, and other end is sutured over the tendon. So advantages of LT transfer are it is a spontaneous activation of the lower trapezius during the attempt of active shoulder external rotation. And anatomy of the transfer lower trapezius to infraspinatus tendon matches the anatomy of the infraspinatus. The shoulder stabilization and the improvement in shoulder external rotation is also improved. So next is the LD with teres major transfer around the humerus. First, we have to make an anterior incision over the humerus. Then we have to detach the latissimus dorsi tendon and also the teres major from the incision. Then we have to turn around the humerus, the tendon, and it is fixed to the posterolateral part of the humerus. We have to be cautious enough that we should not limit the internal rotation by tensioning the tendon. So coming to the pectoralis major, in case of irreparable subscapular tear or irreparable anterior superior cuff tear, pectoralis major transfer can be attained. Pectoralis major has 2 heads, that is clavicular head and sternal head. It has a twisted incision over the anterior aspect of the humerus. Underneath the pectoralis major comes the pectoralis minor and the conjoint tendon. So here, first we have to make a delto pectoral insertion, and we have to find the footprint of the subscapularis. Since the pectoralis major has a twisted insertion, that is the sternal head, which comes from the inferior aspect, it inserts proximally over the humerus, whereas clavicular head inserts distally over the humerus. Our aim is to transfer the sternal fibers of the pectoralis major to the footprint of the subscapularis. Then we have to dissect the pectoralis major from the pectoralis minor. Here we have to detach the sternal heads of the pectoralis major, that is which is in the superior aspect of the humeral head. And after dissecting the, we have to dissect the conjoint tendon beneath the pectoralis major. Then we have to release the biceps tendon, which is further incised completely. Then first, initially, medial row suture anchor is placed, followed by mattress suture is placed through the pectoralis major tendon, fixing to the footprint, followed by the biceps tenodesis. Then we have to mobilize the tendon underneath the conjoint tendon, that is, which thereby protecting the brachial flexus, and it is fixed to the lesser tuberosity. How pectoralis major transfer works, because we know subscapularis muscle is comes from the posterior to the chest, insert in the anterior of the humerus, thereby bringing about the internal rotation. In case of pectoralis major transfer, even though it is an anterior chest group muscles, it passes beneath the conjoint tendon and bringing about the internal rotation of the shoulder. On comparing the momentum, pectoralis minor transfer has better momentum than the pectoralis major transfer, but the moment is smaller than compared with the intact subscapularis and the latissimus dorsi transfer, whereas abductive arms of both pectoralis minor or pectoralis major transfer is comparable with intact subscapularis or latissimus dorsi transfer. So on assessing the movement and strength, there is no much difference in the long-term outcome, whereas pain is improved in case of pectoralis major transfer. Whereas on assessing the range of motion, Only internal rotation is improved in long term, whereas flexion, abduction, external rotation, there is no much difference. So advantages of pectoralis major transfers are pectoralis major transfer improves pain and internal rotation rather than other of the range of motion movements. It has high patient satisfaction. It does not stop arthroplasty progression and superior migration. The revision of with RSA is seldom required. So coming to superior capsular reconstruction, it was first described by Minata in 2016. The goal of the SER is to prevent the superior humeral head migration and to restore the shoulder muscle force couples. It acts by principle of vertical static fulcrum restoration. It is indicated in case of irreparable cuff tear, in case of young patients where RIC is contraindicated, and in case of re-tear after cuff repair. And also it can SCR reinforcement can be used in case of thin cuff where it is the cuff is reinforced along with the graft. SCR is indicated if the age is less than 65, whereas RSA more than 65. In case of cuff tendon arthropathy, SCR is should be avoided where RSA can be delivered. In case of muscle integrity, SCR can be done in dysfunction due to muscle weakness, whereas RSA can be done in pseudo paralysis. Range of motion is better in SCR than RSA. Now coming to the measurement of the graft length, we have to measure the distance from lateral edge of the greater tuberosity to the superior tubercle, and with that, and also in sagittal section, we have to measure the width. With that length, we have to add 15 millimeter extra. That is, after measuring the defect size, along with the defect size, we have to add 1.5 centimeter in length while taking the graft, and also the thickness should be minimum of 8 to 10 millimeter. If the graft length is less than 3 centimeter in AP, then the dissection should be widthwise direction. Whereas in case of length more than 3 centimeter, the dissection of the graft should be lengthwise direction. In fasciolata graft arbus, the incision should be distal to the greater trochanter, and in dissection we have to try to include the intermuscular septum, which adds to the thickness of the graft. So minimum thickness required should be 8 to 10 millimeter. So coming to the surgical technique, first we have to prepare the superior glenoid bed, and we have to pass one suture through the cuff each anchor. That is, medial posterior anchor should be at 11 o'clock position, that is at the base of the coracoid process, whereas the medial anterior anchor should be at the 1 o'clock position, where that is superior tubal. So while passing the graft, all the sutures from the anchor should pass through the graft, and through which the graft should be inserted through the joint. So now the graft is shuttled to the lateral portal, and side-to-side repair of the graft to the remaining cuff is made, which spreads the graft on both anterior and posterior direction. So after in the distal area, we have to make a side-to-side repair at GT bed, that is between the graft and the infraspinatus, and also graft with the comma tissue, stretch the tissue, and not to be tied over the graft at the GT, and followed by lateral fixation, and followed by the graft tying to the great tuberosity. So coming to stability, addition of posterior side-to-side suture between the graft and residual infraspinatus tendon and the underlying shoulder capsule during the SCR adds the superior stability of the shoulder joint. So coming to technical message, massive posterior superior cuff tear with good teres minor, LD transfer is opted, where it improves the forward flexion and also external rotation and abduction. In case of posterior superior cuff tear with no teres minor, LT transfer is opted, where it improves the external rotation and forward elevation. In case of anterosuperior cuff tear with no subscapularis, pectoralis major transfer can be and it improves the pain and internal rotation. In case of thin cuff repair or irreparable cuff tear, SCR reinforcement can be attained. Thank you.
The indication is very, very important. The real indication for a tendon transfer is when a patient has got a massive radiologically proven cuff tear, but clinically the patient should have both weakness along with pain. So weakness and pain in abduction is an indication for a tendon transfer. When a patient has got a radiologically proven massive cuff tear, irreparable cuff tear, but good range of motion, which means the deltoid is functioning very well, and the anterior and posterior force couples, namely the subscap and teres, is functioning very well, but the patient develops pain, which is because of the proximal humeral migration. That is an indication for a superior capsular reconstruction. So you have to be very careful in choosing which procedure is needed for what condition. So painful, massive cuff tear with good range of motion, superior capsular reconstruction is better. Painful, massive, irreparable cuff tear with a weak cuff, yes, a tendon transfer. Now, whether to do lower trapezius or latissimus dorsi, I'm not going to give any verdict over here, but the generalized consensus is right now, latissimus dorsi transfer is being replaced by lower trapezius transfer, because lower trapezius tendon and the muscle orientation is in line with the force vector of the infraspinatus, and hence it acts more as a better transfer compared to lat dorsi. Next most important thing is it is surgically easier to procure the tendon. Both the cases, both the latissimus dorsi or lower trapezius, we need a autograft or an allograft extension to reach up to the greater tuberosity. Now, with respect to these two tendon transfers, either lower trapezius transfer or a latissimus dorsi transfer, I would request you to refer to the articles by Bassem El Hassan, the Egyptian surgeon, who's the pioneer in lower trapezius transfers and lat dorsi transfers, as well as Pascal Bolo, because these two gentlemen have done enormous study on the tendon transfers and published their literature, and in their hands, it works really very well. So it is not for sure that it will work very good in your hand, but you have to respect the principles of the tendon transfers. If we respect properly and do the surgery in the right manner, tailor-made rehab protocol will ensure that the patient will have a functional, pain-free shoulder range of motion, but not as normal as the opposite side. That has to be guaranteed to the patient. The patient should need a pain-free, functional range of motion, but not the same normal motion which is expected in the contralateral side. Superior capsular reconstruction has been very famous, especially in Japanese. The reason is the Japanese health authorities have not approved shoulder replacements, and as a result of which the Japanese shoulder surgeons are pushed towards other alternatives to make sure that the arthroplasty is substituted by some other procedures. So they prefer to do the SCR, and SCR actually really works very well only in hands of Mihata. It is not reproducible. And Mihata insists that you have to take tensor fascia lata graft. The ideal thickness of the graft should be 8 millimeters and so and so dimensions. But SCR can be done in three varieties. One, either you can use the patient's ipsilateral tensor fascia lata and fold it upon to the required dimension, but with a minimum thickness of 8 millimeters. Or you can use the dermal patch allograft from Arthrex, which is called as a graft jacket, which is not available in India. Or the most economical source of SCR is the presence of biceps tendon. You can use a longitor biceps and use it as a SCR. Whether you use any of these procedures, the results are variable, absolutely variable. We cannot reproduce what has been quoted in the literature. So we have to be very, very careful in choosing our patients. A patient with a good compliance, good knowledge, good IQ, and motivated to do good physio and very good pre-operative range of motion. If the patient has got a fantastic deltoid functioning and rotator cuff balancing, SCR is highly likely to be successful. When a patient's rotator cuff imbalance is present, and if you try to opt for a SCR, unless and until you have a good rehabilitation guidelines, I think this surgery will still remain a failure. So you have to be very careful. So understand the basics and the biomechanics of tendon transfers and SCR, and carefully and wisely choose your patients, and then have a very good rehab protocol for these patients to have a functional range of motion and a pain-free shoulder, not complete range of motion, functional range of motion. Thank you. Any questions? If you don't have any questions, sir, can we end the session, sir?
Nothing on plasty and spine, nothing today.
No, next week, sir. Because this week we are having these two topics occupy a lot of time, so we had to finish this. Next week we'll have them. Thank you.
Right.
Thank you. We'll meet for the audit meeting. Thank you.
Thank you.